By logic, stimulants tend to cause hyperactivity. Yet in ADHD, stimulants tend to improve behavior. This apparent contradiction is the key to understanding ADHD, both clinically and both for USMLE. So let's break down this topic of ADHD and understand it right from the neurobiology. Before we understand ADHD, let's understand what exactly is attention. Attention is a neurobiological process where your brain clings on to one task, focuses on one task, and actively suppresses everything else. That is called as attention. Now, at any given moment in the brain, there is some level of spontaneous thought generation, random idea generation. It can vary, but some level of spontaneous thought generation, some level of random memories of the past generation, or the external environment can disturb. There are any noises in the external environment, so all of these at any given moment simultaneously they occur in the brain. So if the brain wants to focus on something, if the brain wants to focus at a particular task, what it has to do is it has to generate signal and it has to focus its attention towards that particular task, and it has to actively cancel out everything else. Now that, my friend, is attention. See, even when you are watching this video, your brain is actively suppressing all the other thoughts. Like you are thinking about maybe replying to the text which is sent by your colleague, you are maybe thinking about having a cup of coffee, but you are still watching the video till here. It means what your brain is doing is focusing, and it is in attention. Attention in formal terms is the brain's ability to select one signal, actively block any other thoughts, irrelevant brain activity, or let's say irrelevant noise. This function of attention happens in the prefrontal cortex of the brain. Remember, the prefrontal cortex of the brain is what is responsible for attention. ADHD has been best understood by something called as signal to noise concept. Now, in a normal brain, what the brain does is the prefrontal cortex specifically, it focuses at a task which is at the hand, and let's call this as signal. So it focuses on the signal, and everything else, all the other random thought process which is happening, it actively suppresses that. Okay, it actively suppresses that. This is how attention is created, when the brain is able to hold on to one signal and actively suppress the noise. Now in ADHD, the ability to hold on to a signal is very weak. This ability is very weak, and the background noise is very big. So anything from click of a pen or any external sound which is happening outside the room, any disturbance can make the patient distracted. The patient, generally the child, he is not actively trying to get distracted. He is not actively trying to switch task. This is because the brain cannot stabilize the focus. Now why in ADHD the brain, the prefrontal cortex, specifically the prefrontal cortex, is not able to hold on to the task at hand, and it is not able to suppress the noise. The reason behind it lies in what I call the neurochemistry of the prefrontal cortex. See, in the prefrontal cortex, in the patients of ADHD, there is a baseline low levels of dopamine and norepinephrine. Okay, so the baseline levels of dopamine and norepinephrine are very less, where in the prefrontal cortex. Now because of that, attention becomes unstable. Attention is unstable. Executive function is weak. And since now the brain is not able to hold on to one particular signal, the irrelevant noise which is happening is more. So therefore impulse control problem arises. The problem of impulse control is also there over here. Now, all of this which we have discussed, it basically explains the attention deficiency. But why it does not explain the hyperactivity? The hyperactivity is because in the prefrontal cortex, there is low baseline levels of dopamine and norepinephrine. What the brain tries to do is that it tries to normalize these levels of dopamine and norepinephrine. How it can normalize the levels of dopamine and norepinephrine? By doing something which creates extra dopamine in the brain. It basically self-stimulates. So self-stimulation is by fidgeting, by continuous talks, continuous movement, running around. These ADHD kids, they run around, they fidget, they continuously keep talking. And what it does, it basically, all of these, this stabilizes the epinephrine, makes the epinephrine and it stabilizes the dopamine. It makes the dopamine level normal. So now the dopamine levels are normal. Now this becomes a cycle. A continuous cycle is going on where the brain is self-medicating itself. The brain is basically self-medicating itself. What you need to remember is that the hyperactivity in ADHD is not due to excess energy. The hyperactivity is a form of self-medication by which the neurochemistry of the child is being corrected over here. It is basically a compensatory mechanism. One thing about ADHD is that ADHD patients can many times focus on video games, sometimes even for hours. Now this confuses students and even parents. Like, why can the ADHD patient focus on video games? This is because video games provide immediate reward, they provide rapid feedback, they provide novelty to the brain, and they provide strong stimulation. So dopamine release increases temporarily. The prefrontal cortex of a patient with ADHD has low dopamine, low norepinephrine. When this patient plays video games, these levels tend to normalize. That is why these patients, they prefer this kind of high dopamine rewarding tasks. Now the stimulant paradox makes perfect sense. Stimulants do not sedate the child. The stimulants, they actually increase the dopamine and norepinephrine levels in the prefrontal cortex. More accurately saying, they normalize the dopamine and norepinephrine levels in the prefrontal cortex. They improve the inhibitory behavior, they improve the signal strength, and they improve the working memory. That is why after giving stimulants, the hyperactivity decreases, the attention increases, because the stimulants, they normalize the prefrontal cortex dopamine and norepinephrine levels. Let us quickly review the epidemiology of ADHD. The prevalence in children, 5 to 10% of children, of all children, have ADHD. Adults, it is only 2 to 5%. When it comes to gender, males are more affected, boys are more affected. Now coming to the DSM-5 diagnostic criteria, you do not need to remember the exact diagnostic criteria. I am going to tell you four categories which the patient should satisfied. First being that most of the psychiatric diagnoses that we have are of a duration of 6 months. Most of the psychiatric diagnoses are of a duration of 6 months. So the symptoms should be present minimum 6 months. This is very basic. Then there are four criterias which needs to be satisfied. These four criterias are, first of all, symptoms should occur in more than two settings. What do we mean by this? It means that symptoms should occur, let's say, at home, also at school, For example, at the dance classes where the child may be going, or the sports classes where he is going, basically more than two sittings, symptoms should occur. This is a very important exam trap. You should not forget it. If they are saying that symptoms occur in only one setting, the examiner is pointing towards SLD, specific learning disorder. But when he is saying that symptoms occur in more than two settings, he is pointing towards ADHD. You should know that. Now, the second diagnostic criteria is that symptoms should start occurring before the age of 12 years. ठीक है. Thirdly, it should cause a functional impairment. What do we mean by functional impairment? It means genuine impairment in academics, in learning, in discipline, and in daily functioning also. Last is that symptoms should be inconsistent with the developmental level. Inconsistent with age. Inconsistent with age. What do we mean by this? It means that you don't expect the amount of attention from an 8-year-old which you expect from an 18-year-old. You do not want an 8-year-old to be focusing on a task like a 18-year-old. Okay? An 8-year-old is not equal to that of a 18-year-old. But if you see that a 8-year-old person is cannot focus on the task which his other batchmates are focusing on, but instead his attention span is of that of a 4-year-old, then we count this as a yes and we tick this. So these are the four diagnostic criterias which should be satisfied. Coming to what kind of symptoms will they give you in the final USMLE or the NBME exams? Here is a list of symptoms of inattention and of hyperactivity. You can take a screenshot of this, and or you can pause the video and you can read it. But what the exams will are going to do is they are going to give one or two symptoms of inattention and one or two symptoms of hyperactivity. Maybe they can tell you that there is a 8-year-old child who becomes easily distracted. He fails to follow through instructions, and he makes careless mistakes. He keeps excessively talking. He keeps running around. So that kind of pattern you should be able to detect, where one or two symptoms of inattention are there, one or two symptoms of hyperactivity are there. Now coming to some differentials. Now these are differentials from an exam point of view, not from a clinical point of view, because in clinical point of view these differentials can very well be the comorbidities also. But from an exam point of view, you need to know the differentials. Generally, the exam won't ask you a question where a patient is having both autism and ADHD. They want you to be able to differentiate between autism and ADHD. So speaking of the first differential, oppositional defiant disorder. Now in oppositional defiant disorder, how do you differentiate between oppositional defiant disorder and ADHD? Basically, the funda that I teach is that a ODD patient will not follow rules. He will not follow rules because he does not want to follow rules. He does not want to follow the rules. Whereas a patient of ADHD, he wants to follow the rules, but he cannot follow the rules. He wants, his intention is there to follow the rules, but he cannot follow the rules. All of these defiant behavior, apparent defiant behavior, which you see, is because of problems in the neurochemistry of the brain. Almost same funda applies for conduct disorder as well. The hallmark of conduct disorder is that the patient does not respect the right of others wantedly. Violation of rights of others is there. He does cruelty, he does aggression, he does destruction. Now a ADHD person may misbehave, he may interrupt, but all of this is not deliberate. Coming to SLD, I have made an entire video of SLD in my last episode of USMLE Psychiatry series. You can watch it. The funda is that SLD is in one setting and it is generally in the academic setting or in a setting which requires some form of learning, speaking, calculation, etc. In all the other settings, the child is good. Then we go for the diagnosis of SLD. Now finally coming to autism. In autism, there are defects in social communication. The patient is having problems with social communications and he has restricted or repetitive behaviors. So ADHD patient might also have social problems, but these social problems are because of his hyperactivity and are because of his inattention, not because of some restricted repetitive behavior or because of some special lack of social skill that is not there. Some things which you should rule out before the diagnosis of ADHD. First thing which you should rule out is the child does not have any hearing or vision problems. If a child is continuously interrupting his parent or other people while they are speaking, it does not mean that he is having ADHD. He could just not be hearing them. Whereas a child who is running around banging into walls and colliding with objects, it might just be that he is having some vision problem. So don't go straight for ADHD. You should rule this out first. A child who is irritable does not mean that he is having ADHD. He could have some sleep disorder. He could have some sleep problems. He could have OSA. A child who is displaying hyperactivity, he could just be having hyperthyroidism. So this also needs to be ruled out. A child who is having impulse control issues, a child who is having hyperactivity can also be having under the effects of some medications, or he may be doing voluntary or involuntary substance abuse. So this also needs to be ruled out. Now one thing that the NBMEs they like to confuse is that they give you a exact picture of ADHD. They tell you that the person is having fidgety nature and he is continuously talking, all of that. Now your diagnosis is going towards ADHD, but somewhere in the big exam vignette they are going to write that he drinks maybe 5 or 6 cup of coffee a day. The child is drinking 5-6 cups of coffee a day. Then you need to go towards caffeine intoxication. You should not pick the option as ADHD in the exam. Coming to the management includes two options. Pharmacotherapy has two main options. First is stimulant, and second line we use non-stimulant drugs. In stimulants drug we can use methylphenidate, we can use various amphetamines. How do these drugs work? They work by increasing the levels of dopamine and norepinephrine in the synaptic clefts. Some side effects which you should be knowing is appetite suppression, sleep problems. The patient may not be able to sleep, insomnia, mild increase in blood pressure, heart rate, emotional liability. All of this can happen. So these are the side effects. Place where they like to test you is when to give stimulant to the patient and when to prefer non-stimulant. This they like to test in the exam. Basically remember that you do not go for stimulant medication when the patient is having a profile which is of abuse, basically drug abuse. High risk of abuse is there, like the patient is has a history of taking some drugs in the school. The child is of ADHD, you are doing the diagnosis of ADHD, but the question stem it also mentions that the child is trying some drugs in the school. He has been caught with drugs again and again in the school. So there is a risky profile is there. Then you don't choose for stimulants, you go for non-stimulant drugs. And suppose if there are any contraindications or stimulants are not tolerated, then you go for non-stimulants. The examples are atomoxetine and bupropion, but basically there in the exam they will test this. They are going to test atomoxetine. Okay, when you should go for methylphenidate and when you should go for atomoxetine. This is what generally gets tested. One type of scenario that they ask is that the child is a perfect candidate for stimulant medications. He is a perfect candidate for starting methylphenidate, but he has a brother and that brother is having a profile of drug abuse. Then you should choose atomoxetine in the options. The management also includes behavioral therapy, and occupational therapy, like classroom accommodation needs to be there, skill training should be there, good sleep hygiene should be there. Many interventions are there which should go along with the pharmacotherapy. But in exams, remember, this is what gets tested. The pharmacotherapy is going to get more tested in the exam, and your ability to choose when to choose stimulant medication, when to choose non-stimulant medication, this is what is going to be tested in the final exams. Now, in order to master this topic, let's solve one or two questions of ADHD. Over here, we have a 9-year-old boy. He is bought by his mother because of poor school performance from past 1 year. Remember that poor school performance also happens in SLD. ठीक है, तो now your diagnosis immediately, either it is SLD or either it is ADHD. By reading one sentence, you can come to these two diagnoses. His teacher reports that he often leaves his seat, interrupts classmates. That is a symptom of hyperactivity. Fails to complete classwork at home. This is very important. At home, because now we are coming to the era of second setting. In the home setting also he is having problems. Home setting also is having some problems, like he is having problems finishing homework. They may say that he has problem doing the kitchen chores, etc. And the mother says that he can play video game for hours. He has a normal development. What is the diagnosis? Now this is where you need to diagnose ADHD. Autism you do not need to diagnose because there is no social problem or repetitive behavior given in the question. Okay. Specific learning disorder, if the problem was only at school, not at home, we would have ticked specific learning disorder. Basically over here you should be able to differentiate between ADHD and SLD. Coming to the second question, is 17-year-old boy, he is brought by his mother for evaluation of poor attention, declining grades from the past 2 years. The teachers report that he is often distracted, he has difficulty completing tasks. So the examiner is taking you towards the diagnosis of ADHD. Symptoms occur at home also. Now again he is confirming, he is giving the example of two sittings. He is having problem at school, he is having problem at home, and the symptoms have begun before 12 years. I told you, for the diagnosis of ADHD, the symptoms should start before the age of 12 years. Now coming to the past history, it says that he has taken Adderall during exams. So, and he has tried it a couple of times. Now this becomes a risky candidate. He who has tried with drugs, he who has experimented with drugs. So for such a candidate, you cannot choose methylphenidate. Otherwise, if this past history was not given, methylphenidate would have been the answer. Methylphenidate would have been the answer. But since the past history is given, you have to choose a non-stimulant drug, which is atomoxetine. Okay. Lorazepam is a benzodiazepine. Benzodiazepine is not given. Haloperidol is an antipsychotic. ठीक है, antipsychotic is not given. There is amphetamine salts. Again, amphetamine salts are stimulants. Stimulants are not given in a patient who is having this kind of a risky drug abuse sort of a profile. So that was today's video of ADHD. If you like this video, you can subscribe to my channel, and I am making a entire episode by episode series that covers the entire psychiatry you need to know for the USMLE exams. I have also done a video of specific learning disorder, SLD. You can watch it over here. I take care. Bye bye. All the best for your exams.